Now, we're set.
Good evening and delightful welcome to Medical Mondays with Dr. O, your forum where we discuss issues and topics related to your health to help you live a better life. Be reminded that this platform is not establishing a doctor-patient relationship, but rather giving you the relevant medical information for you to make the best of your life health-wise. Remember our mantra, strong health, strong future. Medical Mondays is big on your views, so please keep your questions coming and your comments coming via the chat, or you can raise your hand and we will call you to ask your question. This evening, we will be talking about the risk of your heart with Dr. Ashby. Dr. Tonyin Okpesami is a private practitioner, a family practitioner, and HIV specialist, medical doctor, and she is the director of Janassaret Medical Center, and she has passion for Medical Mondays. Welcome, Dr. Ho.
Thank you so much, Honorable Gustav. Tonight, I want to greet you all, welcome you on Martin Luther King's Day. Happy Martin Luther King Day. We have to be grateful for Martin Luther King, for all he did to get us where we are now. We have the freedom to even sit, to learn about ourselves, to improve our health because of things that the people before us have done, especially Martin Luther King. So thank God for another year to celebrate a great man. Tonight, we can't have, any better than Dr. Louis Ashby, a board-certified lifestyle medicine internist who obtained a medical degree from Yale University School of Medicine. She completed her internal medicine residency training at Yale, where she also served as chief resident of the Yale Primary Care Internal Medicine Residency Program. She moved to Florida in 2009 and has, after 15 years of practice, transitioned her medical service to focus on prevention of disease and reversal of chronic diseases using lifestyle, which is why she's so invaluable to us, so valuable, because she uses her expertise to help us prevent disease entities. And that's what Medical Mondays with Dr. O is about. Dr. Ashby's medical experience in internal medicine has led her to create a space for wellness where she integrates healing modalities with the best of Western medicine without the emphasis on pharmaceuticals. Her practice is to reverse disease rather than manage symptoms with medications. She addresses the root causes of chronic diseases. She's board certified in lifestyle medicine, and this allows her to prescribe food as medicine. Her background as a professional bodybuilder helps her patients learn about movement, exercise, and supplements that can promote healing. Dr. Ashby also teaches by example, living the healthy lifestyle herself. In her practice, she spends a lot of time teaching patients about lifestyle. She conducts free Zoom seminars on healthy aging and also does cooking sessions online to promote health. I have attended some of her Zoom meetings. She has internal medicine knowledge, can safely guide and advise patients who are on medications and interested in resolving their lifestyle-related medical conditions off medications wherever possible. Conditions amenable to lifestyle therapies are diabetes, high blood pressure, obesity, high cholesterol, heart disease, chronic kidney disease, and more. Dr. Ashby helps our patients achieve healthy longevity, and her integrative practice in Sarasota, Florida accepts, insurances, new patients, and we are blessed to have her on Medical Mondays. Today, she's going to teach us how to calculate our heart risk and to prevent heart disease if we happen to have it after calculating the risk. So get your paper and pen ready. If you don't have it yet, please make sure you have a pen and paper or your phone with calculator, and you'll be ready to go. Now, I give you Dr. Ashby.
Thank you so much, Dr. O. I appreciate being here, and two of my passions are health and teaching. And so this time where we spend exploring together in discussion on health and learning are really enjoyable times for me too. So I will go into our first slide, and happy MLK everyone on the call.
Happy MLK.
Yes, and today we're going to talk about knowing our heart risk. Heart disease is still the #1 killer in America, at least, and gaining ground globally. And everyone should have a number in mind when they think about their heart health. And that's what I'm going to help guide you through today. You will need your most recent total cholesterol and a recent blood pressure to calculate this when we get to it. So if you want to grab those now, you can, and then all you need is a smartphone. So knowing your risk will involve calculating something called an ASCVD, which stands for atherosclerotic and cardiovascular disease risk. This is what doctors calculate, at least for the most part, when they're trying to decide whether or not someone requires a statin if they have high cholesterol. And so this is what the basic calculation will involve. I'll start with a story. A few years ago, I was in the medical ICU doing hospital medicine, and I admitted someone who had resolved to become healthier. He was a gentleman in his 50s, was newly fiancéed, and decided to go out for a run and start jogging, start the new healthy lifestyle like we all are doing every year around this time. Had a heart attack during the jog, and EMS brought him in. So this was the way that heart attacks surprises people, just like it did him. When he arrived, that he had to be revived and ended up in ICU means that there were pretty significant damage to the heart. And as the week closed and I was passing on the care, and after my week's shift, the discussions had already progressed to organ donation because the gentleman wasn't going to make it and wasn't doing well. So the story I bring up to illustrate 2 points. One is that most people are walking around with a heart disease risk that they could calculate, that they could know, but just don't happen to know it, maybe because they haven't gone over that with their doctor, or they haven't voiced an interest in knowing that risk. And number two, because they don't know that risk, certain behaviors like acute exercise or vigorous exercise matched with a very high risk can actually be dangerous. And this is why a lot of times, if you're a person over the middle ages, you might be asked to get a doctor's permission before you begin on a 30-day challenge or something vigorous, because a lot of things can be avoided, as those things are actual stress tests on the body. So today I'm going to help you know your actual risk. And this risk is not only for the heart, but it's also for stroke, which is also very common in our communities. Just a disclaimer, this is educational. and to help us all get enriched and start conversations with our individual providers. Obviously, you have to speak to your doctor for your own individual purpose. And so this is important to note here, because a lot of times the questions are, well, my situation is this, and well, there's a lot to consider in individual situations, but we'll do our best to enrich here. The top cause of death in this country is still heart disease. It's about some years it's 700,000. A few years ago, it was 800,000. In 2020, it was 690,000 people that actually died. That's more than all cancers combined. And of course, COVID-19, we know, has been ravaging people and causing a lot of deaths in the last few years. Heart disease is still by far, throughout all the years thus far with COVID, #1 killer in America. The 600,000 to 700,000 deaths don't give you the scope of the number of people who are actually sick with this and walking around and, basically possibly waiting for an event if they don't know how close they are to the edge. That translates into about 2,000 deaths a day. And for COVID, if some of you watch the daily deaths in the country, you notice that it hovered between 5, and then when it was going to 6, and then went to peak 800 at some point. And in comparison, it's 800 deaths a day for COVID versus 2,000 deaths a day for heart disease. And that was just half a year ago. So how many people are in this country? About 330 million now, and 121 million of that population, if you also consider the kids who are there, 120 million of that population, which are adults, that's most adults, have some form of cardiovascular disease. And of course, it's only growing, which is begging need for increased education about this. And of note, creeping blood pressure, which is painless and extremely prevalent, is the cause of most of the deaths for heart disease. And it's also a more prevalent condition related to heart disease. Breaking it down by men and women, cardiovascular disease is the leading cause of death in both men and women. And almost half of the population will have heart disease by 2030, which is basically 10 years away. And 2 out of every 3 men in the country have cardiovascular disease. When you look at women, the ratio is a little bit better in terms of prevalence of disease. And women who do die, 1 out of 3 of them who have a heart attack will die. So what's important to note here is that on average, while men get their heart attacks earlier, they tend to live because we are more aggressive as a medical society when a man comes in with symptoms of a heart attack. When women show up, the symptoms are often not traditional. It may not be recognized. The woman herself may not recognize it and present on time. And so as a result, when women do get their heart attacks, they're more likely to die within the year or within a few weeks. But in general, women do get their heart attacks usually after menopause, around the age of 65 and older. So now we're going to calculate a heart risk. If you have your smartphone, I want you to Google this HCC-AHA CVD risk. So if you get,
I just muted Pierre Madoche. I've muted him before. I don't know why he keeps on muting. So sorry about that.
Oh, that's okay. So everyone, if you get to that, you can follow along. This is one of the calculators that can be used for plugging in basic information like your age, your gender, race, which can't change, right? Those are factors, but they are called non-modifiable. because you can't change your age. Oftentimes people are older than they think they are. You can't change your gender, but actually you can now, but put in your original gender, and you can put in your race, because that actually factors into the risk. And then it will ask you for the total cholesterol and the HDL. It also will ask for systolic blood pressure, which is the top number that you get when you do your blood pressure, and the bottom number is the diastolic. If you're on medication for blood pressure, you can put yes. If you have pre-diabetes or diabetes, put yes on diabetes. And if you're not a current smoker, put no. And just hit calculate, and it will spit out a number. Those are the numbers that we're going to spend a little bit of time talking about in the next few slides. I put a couple of different calculators here because this calculator in general is very reliable for the general population, but in some groups, this is also one that can be used. It allows one to put in information like the calcium, the coronary calcium score, if you happen to have it. And so these two calculators are very useful. So as you continue to, find this on Google and locate your numbers and plug them in, we'll go to the following slides that talk about what numbers you might be getting when you do this. This is the other calculator that I mentioned. The populations that this was validated in is a little bit more diverse. And it also includes the coronary artery calcification score, if you have it. It takes into account family history of heart attack. And the rest is essentially the same. So the traditional risk factors for heart disease are mentioned on the left here. The age, gender, race, ethnicity, family history are things that you really cannot do too much about. If someone in the family has early heart disease, that's part of your risk. But these other items are what we call modifiable: obesity, diabetes, smoking, cholesterol, and blood pressure. And those are the areas where we have a lot of room to improve the score that you'll get on these calculations. So what risk is too high when you start plugging in your numbers? Some people might get 5 to 7.5%. That's a 5 to 7.5% risk of having a stroke or heart attack within the next 10 years. That's considered a borderline risk. Optimal would be anything less than 5 or closer to 1 or less than 1. But if it's between 5 and 7.5, the American College of Cardiology and American Heart Association consider this borderline and would actually recommend you discuss a moderate intensity statin with your doctor, especially if there are other things like the family history present or risk factors that we'll talk about in the next slide. So other risk factors that we look at that aren't included in the calculation are family history, unless you use that other MESA calculator, the LDL, which is not exactly plugged into the calculator, but indirectly it's known. Triglycerides, if those tend to be high in the patient. And these two things, which aren't regularly tested at most doctors' offices, actually the Lp(a) is a lipoprotein on our cholesterol that is an independent risk factor for heart events and thrombotic events. So if that's elevated, you can add one more consideration into taking a statin or not. If there's inflammation in the body, as measured by the HSCRP, other lipoproteins like apoprotein B, those can be measured. And chronic kidney disease is also a risk factor, as well as metabolic syndrome and insulin resistance, which is, again, not often tested in most offices. But hopefully in the future, these will become more and more common practice. So after considering these multiple risk factors, if there's still uncertainty about whether or not to go on a statin, your provider may discuss getting a calcium score to help classify the risk as up or down. And the calcium score is a CAT scan that looks at the calcification of the arteries in the heart and gives a risk based on how much calcium is stored in those arteries. So let's keep going with the other two risk buckets that you might get when you calculate your risk. So 5 to 7.5 is borderline. This is where a lot of people end up at the 7.5 to 20% risk. And this is intermediate. So intermediate risk is definitely something to pause about, because either lifestyle therapy is going to have to be extremely aggressive, or depending on the risk factors that we just went over, there might be a lot of other risk factors that encourage your provider to say, okay, moderate intensity statin has got to be on there, or even high intensity, depending on the risk that we just went through, especially if diabetes is uncontrolled, there's family history of premature heart disease, or someone smoking. Again, here, a coronary calcium score can actually help, because if there's no stable, packaged, stabilized plaque that's become calcified, if your score is 0, then there may have been less prior atherosclerosis. But if the calcium score shows a lot of atherosclerosis that's been calcified, then it makes sense to mitigate the risk while you work on lifestyle. So what risk is too high? Greater than 20, definitely, anything above 19, anyone who's pushing 19.9, 18 point something, it's considering the risk factors and then making the right decision. And all of these pathways that I mentioned are current guidelines by the ACC AHA. So what about aspirin? We talked about statin as a modality to help with heart disease so far, and I'm a lifestyle doctor, so I'm going to get to the food, but I wanted to put out there how to calculate your risk, how to know whether you should be talking statin with your doctor, and then aspirin comes into the discussion when the risk is greater than 10%, because especially if there's Lp(a) in the picture, which is the protein that predisposes through thrombotic events or clotting, this could be a lifesaver, especially in the cases of stroke. So you consider an aspirin for some patients with very high ASCVD risk who are not at increased risk for bleeding, because of course every medication has their side effects, and aspirin can increase the propensity to bleed, especially if someone's taking Nsaids and doesn't realize that these two together will affect the lining of the stomach and increase bleeding. Anyone with peptic ulcer disease or prior bleeding or platelet dysfunction should be careful about taking an aspirin without consulting with their doctor. And for that reason, it's not routinely given for first prevention of events in anyone older than 70 years, but if they've had a heart attack already, then it goes on automatically. So here's the fun part. If you don't want to get on medication, if your risk is borderline to low, this is what you would have to do. Increase the greens, increase the fiber, add complex carbs. If you go from eating a carnivore diet to eating a vegetarian diet, by virtue of eliminating animal products, your saturated fat intake will plummet. And if you increase your greens and fiber and complex carbs, the nutrients that are needed to essentially brush cholesterol from the circulation will be increased. In addition to the saturated fats that are known to increase cholesterol, sugars, processed or packaged foods also increase risk of heart disease by way of increasing inflammation and blood pressure. So in this new food pyramid, I call it, The base is made out of mostly greens. I call this the color spectrum. These are both anti-inflammatory, very high in fiber, antioxidants. The sprouted foods, legumes, and some grains here. The legumes are where you would get your vegetable or plant-based proteins, very high in fiber as well. And nuts and seeds for the omegas that are heart healthy, and the unsaturated and polyunsaturated and monounsaturated fats that are needed for heart health. And if someone is very close to having an event or has had an event already and is looking to reverse, the more their diet looks like this, the more they're using food to reverse or prevent heart disease. I just want to go back and mention the portfolio diet, which I'm going to go into. It's one of the diet that's been studied again and again as an adjunct to help reduce cholesterol, and we'll dive into it over the next couple of slides. These eating patterns all will help. If you're still eating animal products, then Mediterranean diet with just a splashing of high fat omega-3 fish will work, and it will help with reducing ApoB, which is one of the proteins that's a risk factor for heart disease. The portfolio diet, I'll give you a little bit more about that, the details of that. Essentially a lot of nuts, seeds, soy protein, vegetarian and vegan are all ways that the pattern of eating can actually be helpful. You'll see here foods fortified with plant sterols and stanols. That is part of the portfolio diet, and I'll tell you more about sterols. The portfolio diet was a study that was first conducted in 2002. It was a randomized controlled trial, and for the doctors in the group, you realize this is a standard that's the highest in terms of studies. It compared lovastatin, which is a low-intensity statin, to the portfolio diet, which I'm going to explain what that contained. High plant sterols, soy protein, viscous fiber, almonds. That's it. That's the diet. So in addition to your vegetarian diet, you make sure you have a certain amount of this portfolio of items in your foods. And the LDL, which is the main thing that statins reduce, is reduced by the portfolio diet and the lovastatin to the same degree. So the conclusion was that portfolio diet is as effective as this particular statin. That gives you a 15% reduction in the LDL. By comparison, the Crestor might give you a 50% reduction in the LDL. So depending on how much reduction you need in the bad cholesterol, which is the LDL, food may do it, or you might have to add a statin. A little bit more detail about the portfolio diet here, because I know people need nuggets to get home and start applying. Plant sterols, it's 1 gram per 1,000 kilocal. It's basically, if you're on a 2,000 calorie diet, you need at least 2 grams of plant sterols, about 50 or 55 grams of soy protein. That's literally like less than 3 ounces of protein from soy. 55 grams is just under 2 ounces, I believe, or maybe it's 50 grams. Viscous fiber, you need at least 30 to 40 grams of fiber a day. And almonds, or any nuts for that matter, a few grams. So usually I say double that because most people are eating more than 1,000 calories a day. So what we see here is that on average, LDL reduced by up to 14%, but in some people, it can be reduced by 20%. So let's say you're starting with a very high bad cholesterol, you can get a good reduction if you actually follow this diet. Again, 50 grams of nuts, that's like 2 ounces a day, 2 grams of plant sterols, fiber, and soy. So as I mentioned, the statin gives you about a 50% reduction, depending on how intense it is and the dosage. And plant sterols give you additional benefit on top of what the statins can do. But if you're someone who's borderline and who needs maybe a 15% reduction in the cholesterol, that's something that plant sterols can help with. So how to increase the good cholesterol? We've just talked about LDL, which is traditionally thought of as the bad cholesterol, which is definitely implicated in heart disease, and that's not debated even within the keto community. So, and you see that in the calculation, you had to put in your total cholesterol and HDL. So HDL has an impact on heart health. HDL is the good stuff. It's the large, fluffy particle that actually helps to clear the blood of the very small, dense, more dangerous and atherogenic cholesterol. And having higher HDL is protective. So how do you increase that? So a little bit about good cholesterol, which is high density lipoprotein. As I mentioned, it carries excess cholesterol from the blood back to your liver, where they're broken down and removed from the body. Okay, so this is why you want a lot of HDL. This is a good thing. And so maintaining high HDL and ideally above 60 is maintaining good heart health. HDL can actually be increased best by the Mediterranean diet in combination with consistent cardiovascular exercise. I mentioned Mediterranean diet because you do need good poly and monounsaturated fats in the diet to help increase HDL. Things like avocados, if you're still eating meat, so fish, tuna, salmon, lots of nuts and seeds, flax seeds, foods that are high in omega-3s. So increasing HDL, in addition to the things I mentioned, if you avoid refined carbohydrates, exercise, weight loss, the activity that happens for someone to lose weight actually increases HDL. With 7 pounds loss, you can increase HDL by 1. And this is very interesting. You know, I'm in the bodybuilding world, and some of the lowest HDLs that I've seen have been in people who are on anabolic steroids and any testosterone-like drugs. And for the doctors in the group, the steroids do stimulate an enzyme, HDGL, which actually facilitates the catabolism of HDL. And so that's why in that population, you see significantly decreased levels of HDL-C cholesterol, HDL cholesterol, and ApoA concentrations, which is something that one might notice with the HDLs, levels in the 20s and 30s. So in general, choose better fats, monounsaturated, polyunsaturated, over saturated, which is mainly animal product, and incorporate those things, and HDL will see an increase. For the people who already drink wine, red wine in particular, has been associated with increase in HDL, and that's a drink a day for women. But for men, if the man is over 65, it's also a drink a day and not 2. So we've really clarified cholesterol, the good and the bad, but heart disease, as many of you already know, is not just about cholesterol. The cholesterol is just one factor. And this is what I think everyone is coming to realize in the medical community. In the 1980s, we thought cholesterol was bad, and then there was a full turnaround to cholesterol is good. We can stop this yo-yo because it's more nuanced than just this simplified version. Yes, cholesterol has an impact on heart disease. And no, it's not just the only factor. About 50% of people who have a heart attack or a stroke, and I say this to my patients all the time, people in the ER are surprised that they were fine, they got a clean bill of health, the cholesterol was fine, but they're in the ER with a heart attack. What happened? Well, it wasn't just the cholesterol. So those other risk factors that were never looked at accounted for a lot of the risk. And if you focus on the cholesterol, you'll miss those. So it's just part of the picture. Let's talk about one other major traditional risk factor, the blood pressure, because it's often overlooked. Its importance cannot be emphasized enough. In the United States, hypertension accounts for more deaths than any other, than diabetes, than family history, than genetics. This is the silent killer for a reason. The blood pressure is slowly creeping up and no pain associated with it. It accounts for more deaths than any other risk factor. So if someone has high blood pressure, they should know what their blood pressure is on a regular basis. And if it's above 120/80, technically it's elevated. And just sharing with you what the doctors see on their end when they look at blood pressure. It used to be that we waited until someone was at this stage to say that they have high blood pressure, which led us to a lot of people not being diagnosed when they could have been reversed early. So now we don't wait anymore to say this is the diagnosis at over 140/90. If your blood pressure used to be 105/60, in your 40s, and suddenly you're 60 something and your blood pressure is almost 130/85, it's gone up. So there's been a physiologic change, and it's usually what's leading to more heart disease. So if the blood pressure is not less than 120/80, have a look at it with your provider and see if there's been a change over time, and begin to work on it. What is the reason for the silent killer being so prevalent and causing so much death? Salt. This is established, and I'll just say a few words on it now. It's been recommended to have 1,500 milligrams of sodium for a long time, but Americans on average are consuming about 3,400 milligrams daily. And while it used to be that chips and different canned foods were loaded with salt, and they still are, surreptitiously, I would say bread has become the content of most of the salt that Americans eat. So you think you're having a sandwich or a slice of bread and it's benign, but if you add that up over time, you're actually getting most of your, salt. If you're not having chips, it's probably coming from bread. So what does the World Health Organization and the US Food and Drug Administration give you a little bit more salt leeway? But these 2,000 milligrams just look like a teaspoon. That's it. So if in your canned goods, the soup that's canned, or the sandwich that was for lunch, or the food that was at the restaurant, you're not accounting for just a teaspoon, you're already over. And this is why the average daily is over 3,000. But what's recommended by the American Heart Association is less than 1,500. In fact, what you need, if there is no other serious illness like heart failure, where salt balance is really carefully managed by cardiologists, 500 to 1,000 milligrams of salt is all most people need. And so that's why the recommendation is here at 1,500. And again, here, more than 40% of the sodium that are being consumed is not from added salt, because most people have figured out that they shouldn't be adding too much salt on their foods. So now it's in the bread rolls. Of course, it's always been in the cold cuts and the pizzas and the cheeses, the salty snacks. But again, here, the bread here. So this is a regular example of a chicken noodle soup with almost 40% of the salt that you need for that day, and versus the low sodium option, which gives you about 6%. So it does make a difference when you read the labels, because most of the salt is coming from prepackaged foods. So what to do if a lot of it is already packaged in foods that you're going to use? So there's some options. You can switch to salt alternatives that primarily contain potassium chloride instead of the sodium chloride. These have been on the market for decades. So you can see the sodium reduction in this brand, for example. I'm not pushing any brand, but there are many, like Mrs. Dash, for example, is a potassium chloride based salt substitute. And you'll see in the subsequent slides that potassium and magnesium are things that are really good for heart health and for vascular health. So increasing those in comparison to sodium actually is doing a little bit of good. So why switch to potassium? The more potassium you eat, the more sodium you lose through the urine. Without going a lot into the details of physiology, potassium lives inside the cells. Most of our body's potassium is inside the cell. Very little of it is outside the cell. That's why when you measure potassium in the serum, the numbers are like 4 or 5. Okay, so it's very tightly regulated outside the cell. When you measure sodium, on the other hand, in the serum, most of the number comes out to 135, 140, 145. So the salt lives outside the cell mostly. So when you have potassium, when you increase potassium, you don't need so much salt. Okay, you lose it through the urine to keep the positive charge balanced. So potassium by itself also helps to ease the tension in the blood vessels. And so increasing the potassium is now actually recommended, and if there's high blood pressure. So the recommendation for potassium used to be about 3,500 milligrams. Now it's 4,700. And so you can find potassium in a lot of fresh foods. I love bok choy. I think potatoes are very high in potassium, which I'll show on the next slide. But you can see how, tomatoes, vegetables are high in potassium. Everybody knew about bananas, but if you look for 22 milligrams, winter squash could be good, tomatoes, and potatoes are actually really good as well in potassium content. So why are we talking about the switch to potassium? Well, it's going to be with the 5% that's added while cooking. You can help there. 6% added while eating. If you eliminate that, you've worked on these two. Of course, the sodium that's naturally occurring, you can't do much about. And then if you read the labels, you can take care of this, large amount that's coming in with packaged foods, the breads, and the restaurant foods. So read labels, avoid high salt, switch to potassium chloride. You can use these things like lemon, ginger, turmeric, and other spices for flavor enhancers. And remember, it's the processed foods that are bringing in the majority of the sodium that's being consumed. So in conclusion, for the blood pressure management through lifestyle, I'll mention the DASH diet because that's tried and true. And this is, again, limiting the salt, and it will reduce the blood pressure in general by about 10 millimeters of mercury, which in some people, that's all they need to bring themselves to a value where when they plug in that blood pressure again in the calculator, it may make the difference between having a statin recommended and not having a statin recommended. And of course, you have the health to boot. A few supplements that come up frequently when people talk about blood pressures include magnesium, omega-3s, potassium, vitamin C, and calcium. I'm not prescribing here. I'm not putting any doses, but these are general, guidelines that could be considered with your doctor. So in conclusion, the foundation for heart health starts with literally food and a healthy lifestyle, because with the HDL, there needs to be movement. And for cardiovascular health in general, that's helpful. Even if you don't remember anything from the slides so far that we've talked about, if you decide to have a new food pyramid, I learned that in the 1970s, the current food pyramid that most people use, with grains at the bottom, meat next, eggs and dairy next, bread somewhere in there, cheeses. That food pyramid was artificially introduced in the 1970s, and there was a lot of interest in the dairy and other industries to help make people get their calcium with dairy and all of that. So we've learned over time about certain choices that can affect our health, and we basically are going back to real food as nutrition, not just for feeling good, but actually for health and longevity. So as you start 2022, I hope this helps you get a good sense of what you can do for yourself, because now, physicians have 3,000 or so patients to take care of. They're not really, they're your partner. They're not doing everything for us. And so we have to have a certain amount of autonomy in deciding to be active in our own healthcare. Since heart disease is so common and prevalent, knowing your risk is important, because you can then begin a conversation with your doctor and not be blindsided. There are so many resources on this. And this is just one that I mentioned with Dr. Joel Furman to end heart disease. And hope you start the new year and stay healthy and well, all of us. So this is where I practice lifestyle medicine. The best way to reach me is probably email if you have a question. And that's the number to the clinic. And I hope 2022 will be a good year, and that all of us will skirt any heart disease mishaps if possible, with added information and focus on our health. And with that, I'll take any questions you might have.
Thank you so much, Dr. Ashby. That was fantastic. Thank you. So just so we can see more of the viewers, if you—
I'll stop sharing.
So that we can, put more, be able to see them on the side. And you can put a face to people asking questions live. I appreciate you a lot. But before we go to questions in the chat or ask people to start asking their questions, I wanted to ask a question, or maybe make a comment about Nsaids and Aspirin. A lot of people don't realize that, Nsaids, things like ibuprofen, naproxen, Advil, what else is there over the counter there, that they can buy over the counter, Motrin, can actually cause bleeding internally that can kill. It can lead to hospitalization. It can kill. Many die, every year from these medications, and combining them with aspirin is just a no-no. So when I saw you put that up, I was excited. Nephrologists on here will be excited that you said that, because they actually wear pins in the hospitals saying that, we should avoid Nsaids, avoid prescribing Nsaids. So when we go out to grocery stores and pharmacies, please, let's be careful what we buy. Ask your doctor before you start taking all these over-the-counter medications. Some of them are not as safe as you think. Because the over-the-counter does not mean that they are safe. So, thank you, Dr. Ashby. I'm going to defer to Honorable Gustav, because we have some questions in the chat box, and I would ask mine later if I have time, if there is time.
Thank you so much, Dr. Ashby. Thank you, Dr. O. The first question from Moses Ademola. Thanks for the opportunity available to ask personal questions through Medical Mondays. Please share some professional knowledge on the significance of comorbidity in the death rate arrogated to incidence of COVID and heart attack.
Yeah, it's a good question. So the heart attack morbidity has remained high, and the death rate as well, because a lot of times when people come in with inflammation and heart disease, one of the ways that they die, even with COVID, is with a heart attack. So COVID normally has a very high inflammation state. So someone comes in with a really high inflamed body from chronic disease, like heart disease or diabetes, and they have COVID, the inflammatory response is also very high. And so cardiovascular collapse is a possibility in the end scheme of things. The other, of course, is respiratory failure. But when the respiratory failure is the cause of death, that's often stated. And so throughout COVID, what's been published, at least in the literature, is that cardiovascular disease has maintained its #1 spot, despite COVID being in the picture.
Thank you so much. Another question. Is change in daily nutrition the only way to reverse the trajectory of health-related diseases?
Well, we certainly have very advanced interventional modern medicine. So once something happens, it's easy to get a cath or a cabbage, but if you don't want to get to that point, yeah, it's looking like food is medicine again. Going back to that, I mean, when we have an obvious way, why look for something else? So yeah, that's the way it is right now.
Thank you very much. A question from John Hervik. Does the potassium sold in the salt-like shaker benefit as well?
Yeah, it's the usual potassium chloride that's now being sold as salt. So that one is the substitute. And if you're able to have a food tracker like MyFitnessPal app, some people are not comfortable tracking things like that. But for the ones who are, it can help keep track of how much potassium you're having. But if you just replace the salt with potassium, that's a great step. The sodium with potassium.
All right. We appreciate you, Dr. Ashby. There's another one from Daniel Akin today. Does potassium chloride taste salty?
Yeah, I mean, a lot of people who try Mrs. Dash or these other substitutes, they get used to it and they don't like going back to salt. Once you've lost the taste for it, it's almost offensive if something is too salty.
Now, Faloshade says, I need to know why I pant when I carry even the smallest weight. Also, when climbing the smallest stairs.
This is a perfect question for a consult or your doctor. There are too many questions that would follow up with that. It depends on the age. It depends on the heart condition, depends on the respiratory condition. It could be just deconditioning if you're young. Is there obesity? All of those can be factors. So that's a question to ask your doctor or schedule a consult.
Okay, thank you so much. Now we have one from Damien Dublin, all the way from England. It says the low dose, that's 1 a day aspirin as a general recommendation. Is it still useful?
Oh, so that's dangerous. See, on one of the slides, I mentioned that in low dose aspirin, which is between 70 to 100 milligrams, if you must know why you're taking it and the risk and the indication, it is not a general recommendation for any and everyone to just have it on board. In general, that ASCVD risk has to be elevated because the aspirin, by way of making your platelets not work very well, it can lead to easy bruising and bleeding if it's combined with other drugs, as we mentioned. So taking an aspirin has risks, and the baby aspirin generally is discussed when there is higher ASCVD risk of greater than 10%, plus other risk factors that would make a clot an event that you want to prevent. In that case, the risk of it being on an aspirin is outweighed by the potential benefit, and so you take that risk and take it. So this is another question to weigh your particular risk with your doctor, but it's not just a general recommendation for anyone above a certain age to be on an aspirin.
Thank you so much. You know, I have a question. When you talked about statin, you know, the calculating the heart risk to decide if one needs statin or not. Statins are those cholesterol lowering medication like Lipitor, Pravastatin, and all of those the cholesterol lowering medications. So it's recommended usually that if somebody has diabetes, whether they have high cholesterol or not, cholesterol lowering agent like statin should be added. Can you comment on that?
Yeah, if you notice on the calculation, anybody who does it, once you put diabetes, the risk almost doubles because the physiology of diabetes is pro-inflammatory. The metabolic disorder comes with a lot of other conditions that increase the other risk factors. So there's often inflammation, there's often metabolic syndrome, there's often low HDL. So if there's diabetes, there's a constellation of disease that exists in that system. And so the statin will lower inflammation at certain dosage and will reduce that risk. So having diabetes is definitely a major risk factor that is modifiable, of course, with lifestyle. But when you add it to the calculation as a yes, people can try this. Try putting diabetes in your number and see how it changes. It really does have a tremendous impact. So that's why the threshold is much lower to add on a statin when there's diabetes on board. Of course, we know diabetes not only accelerates heart disease, it makes it more diffuse. So multi-vessel disease is usually what ends up happening.
Thank you. Thank you so much. We have two people raising their hands. Ms. Karen McDaniel, you can unmute and ask your question. Yeah, you're on mute.
Hello, Dr. Ashby. That last statement you made about diabetes, I guess that is very much on point here. And I put in the calculation that I did have diabetes. I'm pre-diabetic. My last glucose was 6.3. But what is so unusual is, okay, I made a change by mistake. The first time I put in, they asked African American, and I put other by mistake, and I got 4.5 as the calculation. And when I realized that I had made a mistake, I went back and checked African American, and then it went to 7.1. And I guess I'm like, what in the world? So then I said, well, now that you just said that, I don't know if I should have diabetes in there or not if blood glucose is 6.3. So that's pre-diabetic. So I said, that will be something if I take it out and see what I get for African American. But I mean, what a big difference, 4.5 to 7.1, because I'm African American versus putting other. I'm like,
yeah, the risk is actually a lot higher, and this is in population studies also, and that's why some of the calculators, when they're validated in populations that are mostly Caucasian, they miss the risk that are in other groups like African Americans, Native Indian, Southeast Asian, who have inherently a higher risk within those populations. So at least that calculator takes this fudge factor into consideration and gives you a more accurate risk. It does more accurately reflect your risk. Yeah. And the reason I say put yes for diabetes, so the difference between 6.3 and 6.5 is not that much. It's a place that had to be designed to say, okay, this pre-diabetes ends there. So, like a group decided that. It's not because your physiology is different suddenly because you've gone from 6.5 to 6.3. It's the same physiology that exists. So what we don't know about this A1C of 6.3 is whether you also have insulin resistance in the background of that, and metabolic syndrome, which often travels with that 6.3. So considering all of those things make the condition worse and accelerate the condition. And we also don't know about your inflammation level. It's better to be cautious and see what the risks are if all the factors are added in.
Well, I'm working on it because I think when I first was diagnosed, it was 11 point something, and March or something, and I quickly got on it and got it down to like 7.4. Now I'm down to 6.3. My goal is 5.3. I have been meaning to call you and visit you in Sarasota because I am on that lifestyle change. Pandem, I've lost 30 something pounds, even though by scale, by weight, and what I'm right at that, in that zone. So I'm working on it. I ride a bike. I want that 5.3. I'm on a low.
Already from 11 to 6 is great. But you know, you maybe can attest to that, but it's a lot easier than people think. Before we weren't really thinking that we could reverse a lot of diabetes, just control it. But it's good to hear of your story. And
if you count, if you're willing, a lot of people are not willing. I'm willing to count carbs, and I journal what I eat in my cell phone. I mean, I make full use of that Apple iPhone with you know, all that you pay for it with. It gets good use, and I journal in the notes, and I put, you know, what I'm eating and what time and all of that, because like I said, a lot of people in my family have not lived a long time. I plan to be here for a good while. I have 2 little grandsons, so I plan to be here for a while, and I'm gonna keep at it. I want that 5.3.
Kudos. That's wonderful.
That's fantastic. We are proud of you.
Thank you. Put your contact information in there again. I think I have it from another time or two when you were visiting, but you know, I do a lot of things, so I'm not my nonprofit organization that I help out would be remiss if I couldn't. So I have to be here for a while.
Okay, so you'll see the contact information in there.
Okay.
Dr. Ashby did say that, you know, emailing her is the best way now. So we'll post that up for you. And
thank you.
She has a cell phone up there. The best way to do is to text her on that cell phone. So
I will do that.
Okay, fantastic. So Dr. No, we have Folashade Ifonlaja. Mrs. Folashade Ifonlaja. Can you go ahead, please, and unmute and ask your question? There you go.
Can you hear me?
We can hear you, but you're muffled. You are muffled.
Oh, thank you. Please.
We can't make out what you're saying. You are muffled. Can you use your earpiece? Okay, or write your question in the chat box. So while she's doing that, I'm going to quickly go to, you know, Medical Mondays moment. And I want to talk about last week. And Dr. Ashby, last week, Dr. Babita Sandhu was on, and she gave us a gift on Medical Mondays. She gave us a gift of having 6 people actually to coach in a special program that she's using as a sort of research, but to bless people to teach how to eat, change, and reverse disease entities. Of course, she's going to collect data on health and, other data on who will participate. Well, we have 10. And so all week we have talked, and she's agreed to take all the 10. Nice, power of persuasion. So she's taking 10 of ours, and we're going to start the program for everyone on the forum who is part of this, who gave their names last week. I actually have set up the email to send. She's coming up, she's going to send to me. She said, by tomorrow, give it a day or two in case it doesn't happen tomorrow. She's going to send me the layout of what would happen, what you'll be doing the first day we're going to meet, and the rest of that. So I wanted everybody to know that, but I wanted to shout out also that I have somebody on the list that I couldn't find their email. I don't know if, I don't know what their email will be. Alicia Maye, Maye, Alicia. So if you're on the forum tonight, kindly put your email in the chat box so I can have it and I can include you. Alicia Maye, Maye. So we are excited that we're going to be embarking on this program, and in 3 months after the program starts, we're going to come back to report on Medical Mondays what our people have done. So Mrs. Folashade is back. You can try again and see if we can hear your question before we revert back to Dr. Ashby for the
Thank you. Thank you. Can you hear me now?
Yes, we can. We can follow you. It's not great, but we can follow.
Okay. I want to know, is it true that anybody after 60 is supposed to diabetes? 2, I eat very well, and yet I'm diabetes. I want to work to be done. Is it true again that after 60, 135?
Dr. Ashby, can you make that out? She said, is it true if something? That's how far I got.
Is it true that after 60? It sounds like a good question, but I'm not sure what it is. Is it true after 60? What?
That African Americans would go to diet.
Americans
after
would
60 to be diabetic.
African Americans after 60 to become diabetic. Did you say, is it true that after 60, African Americans tend to become diabetic? Yes? Okay, that's the question.
Oh no, it's not a guarantee. That's definitely not a gift for after 60 for African Americans. It's just an expression of the lifestyle. Obviously, the predispositions come in family groups, in the environments, and what has been taught to eat in those environments. So if mom, grandma, and daughter have been eating a certain way, and the grandchild picks it up from an early age, it's environmental influences, not necessarily genetic. So it's not an automatic gift after 60. It's just that after 60, whatever you've been investing in starts giving return, just like in financial world. The health is the same. The investments that are made in your 40s and 30s, you start to see it when you're 50 and 60. And likewise, if you've been debiting a lot from your health, the years, they also disappear on the tail end. And you can actually see accelerated aging on patients who've used up a lot of their health. So the answer to the question is no, it's not a guarantee that after 60 African Americans will get diabetes. That's why I make a point to encourage those who are 30 and 40 to look into prevention, because you can change the course.
Thank you.
Great question. And I want to shout out to our newcomers, people who have never been here, that are here for the first time. Thank you. Welcome. I know we have here Professor Janine Sam. Thank you so much for participating, and welcome to Medical Mondays with Dr. O. I also see my sister here, Rosemary, you know, amazing counselor, huge contributor to our community. Thank you. Welcome. Welcome, and welcome everybody. I can't shout out to everybody, you know, one by one, but you know, we appreciate you being here. So if there are no more questions.
Would they kindly leave their email, those who are joining us for the first time? Please, if you can, leave us your email so we can add you to the list. Also, I want to crave on the indulgence of everyone. It's 2022. Let's go to YouTube, watch a video, like it, share it, repost it. Let's get the numbers going up so we'll enjoy 2022. Thank you all for joining Medical Mondays.
Thank you. Thank you, Dr. Ephraim Ajay. So kindly post your email addresses so we can, you know, capture you and keep you informed every week. So Dr. Ashby, if you please give us your concluding statement and advice, we'll appreciate it.
You know, I think what Karen just mentioned, that it's her own walk, her own work, her own care into her health that's led her to bring an A1C down from 11 to 6.3. All health is in our own hands. You know, gone are the days when the doctor would send you home with a pill and say, call me in the morning. We're dealing with chronic diseases that are brought on by things that we do every day, things that we do 3 times a day eating. And we need to get a little bit more conscious about how we can use those opportunities 3 times a day to improve our health. And begin with knowing your risk first, especially if you're in your 30s, 40s, 50s and are healthy, or you think you're healthy. Now is the time to focus on prevention, is before something happens. So get active with the health and prioritize lifestyle.
Thank you so very much. And I see my daughter all the way from Ghana, Rita, is on. Welcome, darling. I didn't even know.
Thank you.
All the way from Ghana. Do you know what time it is there?
Thank you.
So thank you so much, everybody, for another amazing Medical Mondays. Dr. Ashby, you always blow me off the water. We appreciate you. Thank you. And until next week, everybody please keep safe, wear your mask, maintain that physical distancing, and get vaccinated if you haven't. Eat healthy, your vitamin D, vitamin C, zinc, melatonin, you know, take them to build your immune system and keep safe. We'll see you next week. Thank you.
Bye. Bye.
Thank you, Dr. O. Thank you, everyone. And Happy New Year.
Bye-bye.
Good
Thank
night.
you.
Good night.
Honorable Gustav.
Bye.
She. I'm
Thanks so
sorry.
much, Dr. O. I'll text you. Good night.